Крутая фотка даже.
Угу.
Модельная.
Да.
Скромность, конечно.
Особенно родство. Ой, блин.
Я тебя люблю.
Подожди. Подожди.
Что там?
Угу. Микрофон.
Как ты где?
На конференции.
А это фото как-то.
Тоже хорошо. Подними. Yes.
Hello.
Hello.
Hello, Rokuya?
Konnichiwa.
Hi. Hi.
Is that Rokuya?
Yeah. Hi. Good evening.
Konnichiwa. Here, there.
Yeah. 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 At first, the link couldn't work.
But now it's okay.
Oh, it's okay.
I want to introduce you. It's the Brazilian Northeast Society of Neurosurgery. We are located in the Northeast region of Brazil. It's a minor society, but it's connected to the Brazilian Society. Yesterday, we had almost 150 participants in this platform. Okay.
Okay.
Hello, everybody. Can you hear me? Hello.
Dr.
Hi,
Igor.
Hello.
Where's Rokuya?
Dr. Igor is our president.
Hello. Yeah.
Hello, Professor Tanikawa.
Thank you very much for your invitation.
We are pleased to have you here. Ohayo gozaimasu.
おはようございます。こんばんは。
こんばんは。
こんばんは。
元気でか？
元気ですよ。
Oh,
Benju is back.
Yeah.
はい。
Hi, John. Hi. Hi,
Good evening.
Tanikawa.
Good
Hi.
evening.
Good
はい。
evening.
Good
に
evening.
はおま、にはおま。
Rokuya, do you know how to screen share and everything? I think you've done this before, right?
Pardon?
Have you done Zoom before with the screen sharing?
Mm-hmm.
You know how to share your PowerPoint?
Today I use Keynote. Okay, I can share. I can
Okay.
share the slide.
Yeah, let me show you how to do it if you haven't done it before.
Okay.
Yeah, there you go. Yeah. Okay. Yeah.
Can you
Beautiful.
see it?
Yeah. Okay. Make it bigger. Can you make the screen bigger? There's an option there. Yeah. There. Perfect. You know how to do it.
Okay.
That's good. Okay. You can just get off that now. Yeah, just get off that now so I can introduce you. I'm John Bennett, by the way. Have I met you before? I think I televised you before. I'm not sure. I think I did.
Okay.
Then can I share my screen with him?
Well, only one person can share at the time. Do you have any videos, Rokuya, you have any videos that you want to show?
Okay.
No, do you have any videos you're going to show?
Many videos. Many
Okay.
videos.
Okay,
in the
okay.
presentation.
You know how to play them
Yeah.
and everything? You know how to play them?
Okay.
You want to practice?
I want to show him the Brazilian map for
Okay.
him to localize
Okay.
where we are.
Okay. Okay, go ahead. Go ahead. Try to share a video, just so you're used to it.
Okay. Just a moment.
Sometimes it gets a little confusing.
Okay. Just a moment.
Okay, we got plenty of time.
For example.
Good evening, everybody. Good evening, Professor Rokuya. How are you doing?
Okay. Thank you.
Okay, so the videos are inside the PowerPoint, right? Okay, yeah, it looks,
Can you see
yeah,
it?
yeah, it looks good. It looks good. Okay, so they're inside the PowerPoint, huh?
Yeah.
Okay. Okay,
Can you
Marco,
see
start.
it?
Yes, we can see it.
Okay.
It looks like
Okay.
it's working.
Okay, Marco, Dr. Vieira's monitoring tonight. Are you there, Marco?
Yes. Yes.
Okay, Dr. Vieira's monitoring.
Can you see my screen?
Yeah,
Yes.
Professor, we are here, okay? It's the Brazilian map.
Uh-huh.
Northeast region is this region here.
Uh-huh.
Lots of states and Ceará, Piauí, Maranhão, Bahia, my state, Pernambuco, Rio Grande do Norte. It's this one, okay? That's all. Is the outbreak controlled in Japan now? COVID?
Yes, almost controlled. And maybe tomorrow the emergency situation will be released.
Mm.
Yeah,
Okay.
getting better.
It disturb your surgical daily agenda, surgical schedule?
Yeah,
neurosurgery.
we have a no limitation in my hospital.
Mm.
Works normally.
Yeah. I want to introduce here someone in the panel, Professor Hilda Azevedo, please, if you want to say welcome to Professor Rokuya, be welcome.
Yes, Professor Tanikawa. Thank you very much to join. Perhaps I'm the most senior one here in this audience. And thank you for sharing with us your experience. And we are anxious just to see what you're going to do. And for the young neurosurgeons, I think it's very good for the teaching community and to see your technique and the rationing for performing such a complex and beautiful operation. Thank you very much.
Thank you very much.
okay, Dr. Vieira, where are you at? There you are, Eduardo. How you doing, Eduardo? Where are you at?
Eduardo.
Hi,
Yeah, I'm just gonna introduce you and you take it away, okay?
Mhm.
Okay.
Yeah.
He's the vice president of the Northeast Society.
Okay. Okay, we got 2 minutes.
And all the other friends who want to speak, feel free, ok? Em português também serão bem-vindos. Podem falar e a gente vai conversando, tá ok?
Yeah, if you have any questions, you can put them in the panel, in the chat box, unless you have a good internet connection and you might want to just ask face to face. Alabash, how you doing?
I'm
Yes.
doing well, John. How are you?
Well, you're spending
Rokuya,
some time. You're spending
again?
some time on the computer.
I am, yeah. Always good to see Professor Tanikawa. We met
Hi.
before. Good to see you.
Hi.
Very good. I'm
Hi.
always
He
looking
lives,
forward to your
Hi.
talk.
he lives
Good, good.
You've
far away
lost some,
from us.
you've been working out. You lost some weight.
Yeah. Yeah. Exactly. 75 kilograms.
Running.
No, I am controlling to eat, especially a carbohydrate.
Oh,
Sugar.
change the diet.
No
change.
sugar. I don't take sugar.
Okay. Okay. Just letting all the people in. You know, I tried to raise the limit, Marco and Dr. Vieira, but I can't get through to Zoom. Zoom is so crazy now. Okay, we're ready to start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening, this is Dr. John Bennett, home of, broadcasting from Miami Beach, home of Neurosurgical TV. We have the pleasure of hosting an event for the Northeast Society of Neurosurgeons in Northeast Brazil. And I'm going to turn it over to Dr. Vieira, and he's going to host the events. Welcome, Dr. Vieira.
Hi, good evening, everyone, and thank you for the presence here tonight. I believe you have a wonderful lecture from Dr. Rokuya Tanikawa from Japan, from Sapporo, Japan, and he's going to be talking for us tonight about vascular reconstruction in acute revascularization, the Sapporo experience. Thank you, Dr. Tanikawa. It's a pleasure to have you here tonight.
Thank you.
I want to introduce him, Professor Tanikawa. He is from the Department of Stroke of a Tesnikai Hospital, Sapporo, Japan. It's a very beautiful hospital, and he has operations all over the Asia, lots of courses, including Esculap Academy. And now we invited him to give and share his expertise here on stroke and acute stroke. Welcome, Professor. Feel free to begin.
Thank you.
You okay, Doc?
Your screen, Professor Rokuya. Share your screen,
Okay,
please.
okay.
There you go.
Okay, can I start?
Yeah, a little
Yes.
bigger. Yeah, perfect.
Okay. Thank you very much for your invitation for North Brazilian Neurosurgery Congress. It's a very convenient tool. It's very good because everybody do not go to the place with a wrong flight. It's a very good for everybody. Anyway, today I'd like to share my neurosurgery experience, especially about the microsurgical cerebral vascular surgery and skull base. And later, I will show you my experience of acute revascularization surgically for acute stroke. I always say the same thing. What is necessary for accurate surgery? to see the object in the operative field, this is the most important thing in surgery, to confirm the anatomy, to confirm the situation of the lesion. So to do this, of course, the complete hemostasis is necessary, and we need an appropriate approach to expose the lesion. This is an example of a complete hemostasis. I show this video every time. This is a left side front temporal craniotomy for unruptured aneurysm after skin elevation and a temporal muscle retracted posteriorly from the temporal line. And now the remaining sphenoid ridge is taken out, and the orbital skeletonization are conducted. And the surface of the bone is covered by surgical and the complete hemostasis of epidural space before opening dura. I always force my young guys to get a complete hemostasis like this before opening dura. I hate red cell. This is an important procedure. This is another example of the skull-based approach. This is the left side combined petrosal, anterior and the posterior petrosectomy. At first, I do a mastectomy for posterior petrosectomy. Now, the mastoid bone is drawing away. And now, here is a sinodural angle. The temporal tegmen is skeletonized, the sigmoid sinus and the presigmoid dura is skeletonized. And in the depth, there is a semicircular canals, lateral posterior superior, and the partially end lymphatic sac is exposed. At this moment, the craniotomy is added, and this is a subtemporal approach to a middle fossa. This is a foramen ovale, and the GSPN is dissected. You can see the venous oozing from the cavernous sinus. These bleeding must be completely stopped. And this is a drawing of the temporal rhomboid. I am skeletonizing C6 internal carotid just below GSPN, skeletonizing internal auditory canal, preserving cochlear, superior semicircular canal, and preserving, of course, the C6 internal carotid artery. The important thing, we need a complete hemostasis to see the anatomy. Without complete hemostasis, you can't see anything. And everybody knows the temporal occlusion time of a micro-anastomosis always disturbed, always prolonged by the incomplete hemostasis. If the breathing coming into a subdural space from epidural, it always prolongs the temporal occlusion time. So the hemostasis, always I emphasize hemostasis. And we have to know the way of hemostasis, appropriate way of hemostasis, which is appropriate. Coagulation, use bipolar or monopolar coagulation, or put a surgical gel form covering the breathing point, or using a fibrin soaked gel form or surgical. We have to know, or direct stitching of the breathing point. We have to know the exact way. And most fundamental approach in neurosurgery is cerebral dissection, so-called transcerebral approach. This is an example of a transribbon approach. This is a small left PCOM unruptured aneurysm. You can see it. The PCOM is arising from the medial neck of the aneurysm. This is the left side front temporal craniotomy. And in between multiple superficial cerebrum vein, I am beginning the arachnoid incising. And now I am trying to come into intrasystem by separating the superficial cerebrum vein and small MCA arteries coming up to temporal surface. Here, the temporal lobe and the frontal lobe is adherent with tiny arachnoid trabeculates. We can cut only arachnoid trabecula. Other structures cannot be cut, cannot be sacrificed. With the highest magnification, even tiny veins can be seen, can be confirmed, and gradually we can approach to the target lesion. Here is the aneurysm and oculomotor nerve and the temporal uncus. Aneurysm is adherent to a temporal uncus. And I am trying to put a temporary clip on the supracranial carotid and dissect the aneurysm neck and put the clip. With the highest magnification, I am adjusting the clip placement not to bite the anterior term perforating artery arising proximal PCOM, proximal medial to the aneurysm. The IC green shows the good patency of the PCOM and the corridor arteries and the anterior term perforating arteries. This is an example of a transribbon approach. So, bloodless dissection in cerebral fissure. You can cut only arachnoid membrane and the trabeculates. You can't sacrifice any vasculature. Preserve all vessels, not only arteries, but also veins. Highest magnification to visualize tiny structures in the fissure. You need the appropriate tension to the dissecting point with the spatula and or suction. This is an example of a dural closure. I always use a microscope after the approach and manipulation of aneurysm or bypass. After finishing the microsurgical approach manipulation, subdural manipulation, continuously I use a microscope to close the dura with 5-0 chlorine. I force my young guy to do this. Exact. This is a principal dimension of the dural stitching. If the dural thickness is key, the appropriate bite of dural stitching should be twice of thickness. And the interval of stitching should be 4 times of wall thickness. This is the principle to achieve the watertight dural closure. And of course, the dura must be penetrated completely whole layer like this. 2 times of the wall thickness. The bite should be 2 times of wall thickness. So totally the distance, the penetration point to another penetration point should be 4 times of wall thickness. When we stitch the dura or dura, you can hold the dura with forceps like this, then you can penetrate it. This is a very important principle to do a complete penetration of a whole layer of dura. Same thing can be said in microanastomosis. This is a Averting technique of a donor and recipient vessel wall. The intima must be faced each other. Then you can penetrate the both vessel wall easily. This is the Averting technique. Another important principle is a fish mouth trimming. At the end of a donor, I always cut the donor wall 60-degree oblique cut like this, and same length cutting up. This length can be calculated like this, 2 times of a shrunk diameter divided by √3. So this length is 4 times of a shrunk diameter divided √3. This means that almost approximately 2.3 times of a shrunk diameter. Again, the Averting. This is the principle of microsurgical microanastomosis. So stitching bite should be twice of the wall thickness of a vessel wall, and the stitching interval should be 4 times of wall thickness. This is the principle. This is an example drawing by my colleague Cosmo Noda. This is a very beautiful illustration. This is a final view of anastomosis. After stage suture, the intermediate stage suture in the middle of the arteriotomy, it helps to stitch the vessel wall easily with a fish mouth trimming. And this is the stitching order recently I am doing. After stage suture at heel and toe, first stitch I do just next to a heel side stage suture. Then second stitch at the toe side stage suture. And then in the middle of the arteriotomy, so-called intermediate stage suture. Then you can stitch like this, then like this. So in this stitch, 9 stitches except stage suture. So totally we can stitch 20 stitches, including stage sutures. 20 stitches. So if you spend 1 minute for one stitch, you can finish 20 stitches in 20 minutes. This is a principle. So we should have a training, off-the-job training with a synthetic tube or the animals. Anyway, we should try to finish the one stitch in 1 minute under microscope using a highest magnification. Now, I'll show you an example of anti-temporal approach. This is a modified approach of a trans-Sylvian approach. You can see this is a left side ICA Picon aneurysm. This is a very old video. It's a video in 1998 when I was 36, more than 20 years ago. With the highest magnification of a microscope, you can see even tiny vessels, veins, and trabeculates. Even with non-high definition, standard definition videos, clearly we can confirm the microstructures. The microscope for neurosurgeon is a very strong weapon because it gives us a very clear, highly magnified vision to confirm the microanatomy. And it helps to maintain the patient neural function. Now here, the choroidal artery and the temporal uncus has adhesion by the anchoring of arachnoid trabeculae. And here, the anterior choroidal artery is adherent to the distal neck of aneurysm, and you can see tiny dotted zap just on the medial neck of the aneurysm. With the highest magnification and appropriate approach with appropriate direction to the target, we can confirm, we can see everything. And the CT angio immediately after the surgery. And this is an example of a kissing aneurysm. This is the operation in 2003. Here, PCOM and the choroidal artery aneurysm is so strongly adherent. Partially bleeding happened, but the complete temporary trapping of the aneurysm works well. So I could separate completely the both aneurysm adhesion. This is the first clipping to the PCOM aneurysm. The choroidal aneurysm is bigger and still unruptured. So once I could deflow the ICA, then after recovery of the patient, again, I can put the temporary clip to trap the aneurysm. The problem is like this. Very strong adhesion of the anterior choroidal artery. This small anterior choroidal artery branch is the most important branch of anterior choroidal artery because this is feeding internal capsule. Big trunk of anterior choroidal artery is feeding choroidal plexus, not anterior internal capsule. Small branch always feeding internal capsule, especially arising from a very proximal of the anterior choroidal artery. The small branch is feeding internal capsule. So preserving a small branch of internal anterior choroidal artery is the most important. Even with very exact manipulation, very small high signal was appeared in the gene of internal capsule. Fortunately, nothing happened in this patient. But with a manipulation like that, the tension to the small branch of anterior choroidal artery, which may feed in the internal capsule, has an ischemic complication, asymptomatic ischemic complication. Anyway, to see the object, to see the tiny object with the highest magnification of microscope is very important. This is an example of the anterotemporal approach for basilar SC aneurysm, the relatively high position aneurysm, 7.5 millimeter from the cranial line to the aneurysm neck. This is a zygomectomy transzygomatic approach without OZ. The complete hemostasis again, and approach to basilar with the anterotemporal approach. You can see the stretching of the sphenoparietal sinus. It was released to retract the temporal uncus. And here, the supracerebral artery and aneurysm and a tiny arteries behind the aneurysm. I am putting temporary clip on the visual trunk and right ipsilateral PCA, and confirming the distal neck and proximal neck and small arteries behind the aneurysm. Now, all the branches is detached from the neck, and I am confirming whether the small branch behind the aneurysm is preserved or not. Everything could be preserved. MRI scan and the CT angio show the good exclusion of the aneurysm. This is the next example is epidural antetemporal approach. Sometimes epidural antetemporal approach is necessary because of the draining pattern of the superficial cerebral veins. In this case, this is a small left side PCOM aneurysm. You can see in a preoperative CT angio and after craniotomy, you can see the very big dural sinus on the temporal side is sharing the venous draining with the superficial cerebral vein. In this case, the subdural transcerebral approach is impossible with preserving all the cerebral venous drainage. So I decided to perform the epidural antetemporal approach by incising the meningo-orbital band supraorbital fissure here. After skeletonizing orbit, exposing the meningo-orbital band and supraorbital fissure, dura propria is incised carefully, sharply with a 15 knife, and the anterolateral triangle is partially opened. I am getting a hemostasis with sagittal and the fibrin soft gel form. And that is the foramen rotundum. The V2 is still covered with the dura propria. Now I am incising dura propria on V2 of trigeminal nerve here. Now the V2 is gradually exposing. Now you can see the V1 and the V2. Between the V1 and the V2, there is an anterolateral triangle, and partially the lateral loop is open and the venous breathing from the lateral loop is coming. It can be stopped with the sagittal. And you can see in the middle of the operative field, the fourth nerve can be confirmed here, like this. This is a very important anatomy. Here is the anticlinal process, supraorbital fissure. Third nerve is running. The fourth nerve is running here. B1 and the B2. Here is anterolateral triangle. Partially open the lateral loop for lateral triangle. This is a confirmation of the lateral cavernous sinus wall. At this moment, the frontal dura can be inside linearly toward the apex of anticlinal process. And the dural incision can be extended toward the oculomotor foramen. With the high magnification, you can confirm the foramen oculomotorius could be opened sharply. And I am confirming the fourth nerve learning course, and that is I'm confirming the trochlear foramen as well. This is a proximal cerebral dissection to secure the retrocaudate triangle. Here is the cisternal oculomotor segment. The arachnotrabecular posterior to oculomotor nerve should be incised because by retraction of a temporal uncus, the trabecular between the uncus and the oculomotor through the oculomotor nerve posteriorly laterally, and it causes post-operative oculomotor nerve palsy. So the incising, freeing oculomotor by the anchoring of tiny trabeculae is very important. And now the ICA and the P2P1 segment, oculomotor and aneurysm and PCOM. Aneurysm is attaching to the postcrinoid process. We can confirm it and sharply, directly detach the aneurysm. The Litigation membrane behind the aneurysm, medial to an oculomotor, can be incised, and you can expose the visual tongue. Now, the parent artery condition is not bad. You can put a temporary clip on the supraclinoid carotid, and put the tentative neck clipping on the aneurysm in order to preserve the anterior term perforating artery arising from the proximal PCOM. Then temporary clip could be taken out. This is an actual procedure of epidural anterotemporal approach. Next case is thyroid hemorrhage with a temporal hematoma. A relatively large ruptured aneurysm, right side. This is a no-cut video of acute surgery. Now, the preparation is finished and skin incision is begun. In 10-12 minutes, the dura is opened, and here is the orifice of the temporal hematoma. This is a decompression by a partial removal of the hematoma, not to injure the breathing point of the ruptured aneurysm because the hematoma is connecting to the ruptured point. Now, temporal clip on the supraclinoid and the C1 segment of a carotid, tentative trapping of the aneurysm, then you can put the clip on the neck with reducing the aneurysm tension because the aneurysm is very big. Without reducing tension of the aneurysm, it causes a neck laceration. So the reducing the tension of the aneurysm is very important. And this is oculomotor adherent to the aneurysm. Here is posterior to the oculomotor. Here is the injured part of the temporal uncus by the rupture of the aneurysm. Now, the completely aneurysm is detached from oculomotor nerve and confirm all the anatomy, preserve the PCOM and the anterior perforating artery. IC green shows well. And this is a post-operative CT scan and the 3D CT angio. Complete neck clipping, no neck remnant, especially a medial part of the aneurysm. We have published of the complete clot removal by meticulous irrigation and the continuous low dose administration of nicotine, intravenous nicotine, to prevent a symptomatic femoral vasospasm on a ward of neurosurgery. So, bloodless dissection in Sylvian fissure is very important. You can cut only arachnoid membrane and the trabeculae. Preserve all vessels, not only arteries but veins. Highest magnification to visualize tiny structures in the fissure. Provocation to the dissecting point with spatula and or suction. And the meticulous rinsing and the irrigating subarachnoid clots in dissected fissures to prevent direct vasospasm. The time is limited, so I skip the anterior inter-hemisphere approach. Next, we can discuss the therapeutic carotid occlusion with high flow bypass. This is several representative cases of high flow bypass for therapeutic carotid occlusion in order to exclude the complex large giant carotid aneurysms. The high flow bypass using a radial artery or saphenous vein between the external carotid and the M2 segment of a middle cerebral artery is very effective and simple, very good procedure to treat such a complex lesion. Until 2018, I have 117 cases for almost 20 years. The graft patency was 96%. The post-operative recanalization of aneurysm was 1.7%, 2 cases in 117 cases. All of 2 cases was a cavernous segment giant aneurysm with a proximal ligation. I had no post-operative rupture after surgery. Overall outcome was excellent. The modified ranking scale 0 to 2, almost 95.6%. Giant, almost same. Large, 100%. Blood blister like ruptured aneurysm, the 67% was modified ranking scale 0. But remaining 33% ranking 3. But the important thing, with this procedure, we have no mortality. This is an example of a 74-year-old female, previously coiled, complex, thrombosed, giant ICPC aneurysm. This is a neck preparation before opening head. Then STA is prepared, front temporal craniotomy is performed, and again, distal transribbon approach to expose the whole M2 segment, M1 segment, and aneurysm. This is a preparation for STMC bypass on M3 segment, and the M2 segment is exposed for radial artery anastomosis. Now, the STA, one of the STA branch is anastomosed to an M3 segment as an end-to side anastomosis with Fishman framing on the STA. You can see with the highest magnification, you can confirm the exact penetration point of the 10-0. And after finishing one side, confirm inside whether there is a mouth stitching or liver stitching with the other side wall. It's very important. Then the STMC bypass is finished, and the bypass is open. The icy green shows the good patency of the STMC bypass. And this is another remaining branch of STA. It is cannulated with a 22 gauge venura, which is connecting to blood pressure monitoring. And this is a radial artery M2 bypass. The cannulation to a STA is for a purpose to monitor the MC pressure before and after opening a bypass. Anyway, this is a radial artery M2 anastomosis with a 9-0 suture. With the highest magnification, you can see everything of each vessel wall, donor and recipient. You can see it's a very easy condition to penetrate both vessel wall and confirm inside. And this is the next stitch to toe side. Now, this is a preparation for a graft placement to the submandibular root. This is a chest tube, 22 gauge chest tube, and the radial artery is expanded with heparinase saline like this, and they put the 724 Yasha gel clip to maintain the expansion of the graft in order to avoid the twisting of the graft during the placement of the graft in the submandibular tunnel. After placing the graft, again, graft is expanded to remove the twisting or kinking, and external carotid has arteriotomy with aorta punch. This is a 7-0 pronova with a lining suture. Then the cervical ICA is clamped. Then the radial artery is open. Now, the blood flow is provided to the brain through the radial artery graft from the external carotid to a middle cerebral, and I am confirming choroidal artery is patent by the high flow bypass. Now, with the ICA occlusion, the anterior choroidal artery could be preserved. So, in this case, just proximal ligation of an internal carotid artery, then no touch aneurysm. Patient recovered well without no neurological deficit except persistent oculomotor nerve palsy. This is an example of the MCA pressure monitoring through ST-MCA bypass. One of ST branch could be cannulated, which is connecting to a pressure transducer. Now, by clamping the ST trunk, you can monitor the MCA pressure. Like this, MCA pressure is 62 millimercury in mean pressure. After ICA occlusion, you can see the MCA pressure decline 62 to 43. By opening the graft, the MCA pressure recovered from 43 to 57. It's 92% to a control MCA pressure. This is a real-time monitoring of a graft functioning. IC green shows good condition as well. This is an example of MCA pressure monitoring through the ST-MCA bypass by clamping the ST trunk. I'll show you a malfunction of a bypass graft. under the MC pressure monitoring. Here, after high flow bypass, ICA clamp, MC pressure decline. Now, graft is open. MC pressure 30 millimercury. By opening graft, it's slight elevated, 42, 43 millimercury. I am feeling the pulsation and the pulling up, no pulsation. You can see the 180-degree twisting of the graft. This was the cause of the graft malfunction. The MC pressure monitoring is very sensitive to this kind of complication. Now again, graft is twisted, then press the graft and re-anastomosis, and again MC pressure monitoring. The 73 millimercury control pressure declined to 42, and it immediately recovered to a 50, 60 millimercury after opening a high flow bypass. Like this. So the monitoring whether the graft is working well or not is very important during surgery. With this procedure, we have a very good result of the high flow bypass. According to our study, we realized that the MCA pressure ratio before and after, before occlusion of internal carotid and after occlusion of internal carotid with opening bypass, MCA pressure ratio should be more than 0.8. 80% of MCA pressure compared to a control MCA pressure is necessary to avoid post-operative hemodynamic ischemia in a therapeutic carotid occlusion with high flow bypass. We have published it on World Neurosurgery in 2015. You can see it. So during surgery, the MCA pressure monitoring is quite important for evaluating the bypass functioning. So important thing is the MCA pressure. And as well, before surgery of the therapeutic internal carotid occlusion, we perform the balloon test occlusion with monitoring, measuring the stamp pressure after the occlusion of ICA with balloon. During balloon test occlusion, after inflating balloon of ICA and occlude ICA, if the stamp pressure was more than 80% to control ICA pressure, basically there is no indication of revascularization because, as I told you, if the MCA pressure after occlusion of ICA, regardless bypass is provided or not provided, the more than 80% of MCA pressure could be maintained and nothing happened. So in a balloon test occlusion, if the stamp pressure was more than 0.8, we have no surgical indication of bypass. But in almost cases, the stamp pressure is less than 0.8. So less than 0.8, we need something revascularization. So how can we determine the graft size for therapeutic carotid occlusion? The we have a many discussion for a long time. The low flow bypass is good for therapeutic carotid occlusion, or as I emphasize, high flow bypass is necessary for ICA occlusion. We have many long discussions, but simply according to Hagen-Poiseuille's law, the provided flow by the vessel is proportional to the diameter, like this. It's the simple proportion, the simple principle. This is the model of the ICA blood flow. With the ICA patency, the provided blood flow by ICA is a red part. And collateral flow through the contralateral ICA, through the ACOM, and alcohol flow from vertebral vaginal system, like this, ACOM flow, and the left meningeal anastomosis from PCA, as well from the vertebral vaginal system. When we perform the balloon test occlusion here, if we occlude here, we can measure the stamp pressure. The stamp pressure measured by balloon test occlusion is showing the collateral power of these collaterals. So after the ICA occlusion and the high flow bypass is made like this, and in almost case, the graft size, regardless radial arterial surface, graft size is smaller than the ICA diameter. So the pure provided blood flow by ICA is here, this part. And the remaining, this green part is the blood flow provided collateral flow. This can be defined as K. This part can be defined 1 minus K, like this. After bypass, the graft flow like this, but collateral flow is the same. So the total blood flow by after bypass, regardless high flow or STMC bypass, expected flow ratio here and here, it can be calculated like this, because this part is proportional to square of the diameter ratio between graft and ICA. Larger means the ICA diameter. Small r means graft diameter. It's a simple quadratic function. With this formula, we can plot the graph like this. This is at y-axis at x0, if the remaining blood flow has a collateral power. If collateral was poor, depending on the graft size ratio, the curve like this. And as I told you, MCAP ratio should be more than 0.8 to avoid ischemic complication. So we need this part after surgery. So again, MCAP ratio, if it was less than 0.8, patient have the something hemodynamic ischemia in our series. But with conservative treatment, patient recovered well. These series, which indicate post-operative hemodynamic ischemia, all cases has been performed the high flow bypass using radial artery or saphenous. If the MCA pressure ratio or CBF was more than 80%, nothing happened. Nothing happened. This is important, 80%. So with this formula, we can calculate the example. With this formula, we can modify this formula as R, like this. If flow ratio is necessary more than 0.8, you can put 0.8 to here. It can be calculated. Graft size should be more than 0.9 to diameter of supracranial internal carotid. If the supracranial carotid diameter was 4 mm, graft size should be more than 3.6 mm. With this formula, we can determine the appropriate graft size, which can obtain the more than 80% of blood flow compared to ICA. Again, this is the graft protein based on this formula. And additionally, this is as well important thing. If the recipient, which we choose as a recipient for radial artery or saphenous vein graft, if the diameter of the recipient was too small, it becomes a bottleneck. So to avoid the bottleneck, we need an appropriate size of a recipient. What size is appropriate? It can be calculated like this. If the peripheral, the vascular resistance was the same in the proximal and the distal, it can be calculated. The provided blood flow by the graft is divided equally to proximally and distally. So the area of a recipient can be calculated like this. Then appropriate size of a recipient should be more than due to 0.5. This means that more than 0.7. So the recipient size should be more than 0.7 to graft size, right? We have published it on a Journal of Neurosurgery in 2017. Please read it carefully, and this is very useful to determine the appropriate graft size for therapeutic internal carotid occlusion and confirm the functioning of the graft properly or not during surgery, real-timely. Okay, it's very important. So square stitch of a micro suture, microanastomosis is important. Square stitch means that bite of length should be 2 times the wall thickness. Interval of stitch should be 4 times of wall thickness. Fishbone streaming is a principle oblique cut with 60 degrees at the donor end and the same length cutting up. Averting, Intima to Intima. Arteriotomy length of side-to-side anastomosis. I couldn't mention the side-to-side, but arteriotomy length in side-to-side anastomosis, it should be more than 3 times of the diameter. And in side-to-side anastomosis, bottom side always inverting, not averting. This means that in a side-to-side anastomosis, the collagen fiber of the cutting edge of the wall is exposing inside of the lumen. So it may cause the acute thrombosis. To avoid the occlusion of side-to-side anastomosis, we need a big orifice. To obtain the big orifice in the side-to-side anastomosis, we need at least 3 times of length of diameter of the parent artery. And in therapeutic carotid occlusion, we can measure the MC pressure ratio. This is equivalent with the flow ratio. It can be calculated with this formula, 1 minus K times the square of a diameter ratio plus K. K means the remaining collateral flow. Diameter of the recipient should be 0.7 times of a donor vessel. This is a principle to perform the microanastomosis. I can go to next talk about the acute revascularization. Acute revascularization. Just a moment.
Okay.
Okay. Can you see it?
Yes.
Okay. So we can discuss after this talk everything. Nowadays, many of you has experience of acute recanalization of acute stroke with endovascular therapy. I have nothing to. I have a disclosure of the Takayama Instruments. I have a patent fee. Anyway, I have been performing the surgical embolectomy, surgical revascularization for acute stroke in this more than 20 years. Nowadays, endovascular thrombectomy became a standard procedure after 2015 Nashville Hope. But now, in our hospital, we are trying to do a surgical embolectomy as well after the failure of the endovascular recanalization as a third procedure. This is my colleague in my hospital. They are all neurosurgeon, and these 3 guys are all endovascular surgeon. All endovascular surgeon who they are they have a training of a surgery under me in this 3-5 years. All young guys, all 30s, 40s. In Japan, even acute stroke, at first, as a first contact, neurosurgeon treats them. So we are cooperating each other to treat such a patient. The target region is carotid, MCA, and rarely basilar trunk or PCA. This is an example of the MCA occlusion like this. Immediately, we can start the study, diffusion weighted image, MRA, and T2 star. We can finish it in 15 minutes with MRI scan. After MRI, immediately we perform the 4D CT angiogram with a 320 row CT scanner. Simultaneously, we check the aortography like this in order to check the aorta dissection. Many of patients have, sometimes, occasionally, patients have the aortic dissection. And as well, without aortic dissection, patients have the very sclerotic tortuous aorta. And the problem is the ischemic complication of the intestinal colon with a very hard atherosclerotic change of a supramesenteric artery or inferior mesenteric artery. And as well, we can confirm whether the renal artery has a good enough size or not. This means that post-operatively, patients have something renal failure with low flow of renal artery. Sometimes often happen anuria after surgery. So we always check the aortography and intracranial. By a diffuse 3 study, after 6 hours from onset until 16 hours, even after 6 hours until 16 hours, the endovascular recanalization had advantage in prognosis. So after diffuse 3, we prolonged the golden time to 16 hours. But after that, we had a Dawn trial. In a Dawn trial, after 16 hours to 24 hours, still endovascular recanalization has a very good result. So we now, our golden time to treat the acute thrombosis is prolonged until 24 hours. Very important. Like this, the thrombectomy prognosis was quite significantly good compared to medical treatment. So, the treatment for acute lip perfusion in a hospital is like this. If patients come within 4.5 hours, at first we try to do an intravenous TPA, and simultaneously patient transferred to an angio suite, and we try to do angiography, and still the artery was occluded. We try to do endovascular thrombectomy immediately. If patient come after 4.5 hours, and now until 24 hours, we do the endovascular thrombectomy directly without TPA. after procedure of endovascular thrombectomy, if still recanalization could not be achieved, if patient condition was tolerant, we try to do open craniotomy, emborectomy. This is an indication in our institute for acute stroke. It's a same with other big studies. In this 8 years after I moved to Sapporo, we had 118 cases, surgically 38%, endovascular 62%. After Nashville Hope, here, Nashville Hope, until Nashville Hope, we did open craniotomy and surgical emborectomy. But after Nashville Hope, we switched to endovascular first. Last year, all cases were treated with endovascular. These are clinical characteristics between surgery and endovascular, almost same. This is a location of occlusion, almost ICA and MCA. Surgery and endovascular, almost same. This is an example of the left ICA occlusion. Diffusion image shows a very slight high signal in intracortex basal ganglia. You can see the susceptibility vessel sign of carotid and M1. You can see this is exposure of MCA and the carotid. You can see the supracranial carotid and the ICA bifurcation. The M1 is occluded with a very big thrombus. Now I am pulling out the thrombus, and the assistant put the temporal clip on the proximal to the incision, and I am pulling out the thrombus from the A1, and the cross flow through the ACOM is coming. And still the thrombus remain in the M1 segment. It can be pulled out. And the M1 is occluded. At this moment, temporal clip on the carotid is replaced distal to a choroidal artery. Then now, choroidal artery is reflowed. And the incision is stitched with 4 stitches. And the IC green shows good patency of choroidal and A1, M1. The diffusion shows no extending of the high signal area. The patient recovered well. Another case, 75-year-old man, cardiogenic basal artery occlusion. You can see the basal artery occluded on MRA. At this moment, patient is comatose, and the CT angio shows delayed filling of a right ICA because this patient have the right common carotid occlusion with collateral flow through the orbital flow from the basal artery to the right ICA. So, to save the patient, the canalization of a basal is necessary.
É que tem barrigão que a gente encontrou lá algumas vezes a gente encontrou em Gravatá, em do Lions, Tá lembrando mais ou menos?
Sorry about that.
Anyway, 20 minutes from a skin incision, you can approach to a basal bifurcation. Here is the origin of a P1 after temporary clip on a basal trunk. And I am pulling out the thrombus in ipsilateral P1 and the basal bifurcation. You can see it. And push out the thrombus in basal trunk. I am massaging the basal trunk. Then the blood is coming out through the contralateral SCA and perforated. Now, the 3-4 stitches to occlude the incision. Now, it's a 45 minutes from a skin incision. Then you can take out the temporary clip on bilateral PCA and laser cut. It's a 49 minutes from a skin incision, complete reflow of the basal trunk and the bilateral PCA. Icy green shows a good fitting of a PCA and good fitting to a right ICA. This is a final view, and post-operative CT angel shows a good fitting of a basal trunk and the right ICA territory. The CBF is good. Patient recovered well. This is an example of the STMC bypass after failure of the thrombectomy, because here, this is a right M1 occlusion, M1 distal occlusion, and the M2 occlusion. The thrombus inside of MCA could be taken out. But the problem is, patient had a very strong arteriosclerotic change. And after taking out the thrombus like this, because of chronic injury of intima and additional acute injury of intima, even the blood flow coming like this, the blood flow is good, like this, and confirming the good blood flow. And after stitching it, this is a super trunk of M2. Super trunk of M2 can be reflow, like this. And the remaining inferior trunk of M2 can be stitched and open. But confirming the Doppler sound was poor. So, in this case, I decided STMC bypass, harvesting the STA, and this is one of the STA branch. It is anastomosis to inferior trunk of M2. Like this. And another branch is anastomosis to a super trunk. In this case, both branches of M2 is saved by a double barrel bypass. You can see the high signal in the basal ganglia appeared, but the patient recovered well. This is a 4-year later MRA. The STA grew up bigger, and ICA is feeding the PCA and A1. This is a result of a process time, overall process time of 118 cases. Patient come within 1 hour from onset. Door to puncture or door to skin incision for surgery is 53 minutes. And from puncture to deep perfusion or skin incision to deep perfusion was 50 minutes on average. In the endovascular, the patient comes with 1 hour, And the door to puncture was 67 minutes. We should shorten this time more, but less than 60 minutes. And from puncture to reperfusion was within 1 hour. Surgery. We need more time to prepare. So it's 84 minutes from door to skin incision. And from skin incision to reperfusion was 41 minutes. It's 40 minutes. It is faster than endovascular. But totally, this time is 2 hours in the surgery, and endovascular as well, 2 hours. Oh, similar. The modified ranking scale at 3 months, overall like this. Now 48.2% modified ranking 0 to 2. Endovascular is a bit worse than overall result, 45%. Surgery is relatively good, 54%. It is similar with other big studies. TT score, overall 75%. Endovascular, 71%. We had one case of access impossible. Open surgery was 84%. Complication, we had 6% of hemorrhage and 5% of death. Endovascular, 7% of hemorrhage, 5% of death. Surgery, 4.4% of hemorrhage, as well death. I'll show you an example of a rescue of complication. This is a 69-year-old male, left M1 occlusion. This is a trying of endovascular recanalization. Now, the M1 distal embrus could be taken out. And the M2 still occluded, so my endovascular colleague tried to recanalize, but perforated. So immediately we transfer the patient to OR and open head because the bleeding is continuing. It's 30 minutes from a skin incision. Immediately I am trying separating this cerebral fissure to expose the bleeding point. Here, you can see. Now it's a bleeding point. Put the temporary clip to control the bleeding. And extend the dissection of the cerebral fissure. Now, fully expose the M2 segment and M3 bifurcation. And I am stitching the perforation point like this. Then you can reflow the blood flow. The IC green shows good patency of the right side branch, but still occluded the inferior branch with the thrombus. The surgical thrombectomy can be done like this, even after failure of endovascular recanalization or with something perforation complication. This is the recanalization time was 54 minutes from a skin incision. The diffusion and the CT scan shows no change before surgery, and full recanalization, and the patient recovered. So, in our institute, the treatment flow for acute stroke is like this. At the first line, within 4.5 hours from onset, we can use the tissue plasminogen activator. If more than 4.5 hours until 24 hours, directly we choose endovascular thrombectomy. After TPA, immediately transfer the patient to angio 3 to confirm the recanalization in angiography. After failure of endovascular thrombectomy within 16 minutes, we decide whether we should perform the open surgical embolectomy or not. Or if something hemorrhagic complication happen during endovascular treatment, we choose open surgical hemostasis or embolectomy. So in conclusion, the overall good outcome was 48%. No significant difference between endovascular and surgical recanalization. Acute recanalization was effective, and the neurological prognosis was good with short process time, regardless endovascular or surgical. Open embolectomy or emergent STMC bypass can be your third line after the failure of endovascular recanalization. The advantage of surgical embolectomy is not only to decanalize occluded vessel, but also to repair the injured vessels during endovascular procedure in very short time. Endovascular and surgery are not versus. We can collaborate. We can compensate. So this is what I want to emphasize in this topic. That's all. Thank you very much. And finally, I would like to announce about the Far East Neurosurgery Sapporo Live Microsurgery course. This year it's canceled, but next year I hope we can have this live course. Next year, July 18 to 23. As usual, we have a bypass hands-on course in the morning on Sunday, educational lectures in the afternoon, and from Monday to Friday, we have a live surgery, at least 2 to 3 cases. If you have an interest, please join us. Thank you very much.
Okay, Dr. Vieira?
Yes, thank you very much, Professor Tanikawa, for your brilliant presentation.
Thank you.
I'm sure we all learned a lot tonight. And I would now like to open for questions from the panelists. Let's start. Professor Yudo, you want to say something or ask something?
Oh, yeah. Thank you, Dr. Thank you very much, Professor Tanikawa. It was a very impressive and teaching lecture. Congratulations for your expertise. And again, it brings me the issue that I did mention yesterday, that the young neurosurgeons, they need to go to the lab if they want to remain in the neurovascular surgery. They need to be experts on all types of EC, IC, and internal IC anastomosis. My question to you goes to your first slides, actually. When you talk about stump pressure, when you do you think that measuring the stump pressure, are you abolishing the BTO test? So you just rely on the pressure, or you carry on doing the traditional BTO test, occlusion, decreasing the blood pressure, or just the measuring the pressure is enough for you to decide whether or not that patient would support or not the ligation of the parent vessel? Thank you very much.
Thank you. Yeah, in our institute, we do just measure the stump pressure only. we never performed the pressure decreasing during balloon test occlusion. The reason why is because the patient who need the balloon test occlusion always have the complex large giant carotid aneurysm, and many complications has already been reported during balloon test occlusion for a long time, around 20 minutes, 30 minutes, with blood pressure declining, because the many of complication is due to thrombus formation inside aneurysm during balloon test occlusion. Even with the systemic heparinization, by balloon occlusion test, the thrombus formation inside the aneurysm always happen. This is a big problem. Because you know the balloon test occlusion is just an exam before treatment, not a treatment. But with such a invasive examination, in my opinion, we should avoid such a complication. So this is the biggest reason why I don't decrease the blood pressure during balloon test occlusion. And just measuring MC pressure, as I mentioned, if stump pressure was more than 0.8, 80%, more than 80%, no revascularization is necessary. Just a simple occlusion of internal carotid works well. So just measuring stump pressure in order to know the total collateral power through the ACOM and PCOM and left meningeal power from a PCA is
thank
good
you.
enough.
That's a very useful information that not only saves time, but also saves some complication, as you did mention. Perhaps our endovascular colleague is in the audience. Dr. Gustavo would like to go into this BTO issue. Dr. Gustavo Pivot is there. I hope he is. If he's not, I think Dr. Eduardo Ernesto is in the audience. He could also comment on that. Eduardo Ernesto, are you there?
Yes. Yeah, I'm very surprised. I think first, thank you for a very nice presentation. I'm very impressed. It's I am especially surprised by this case with perforation during thrombectomy endovascular. And normally we see when we have a perforation in few minutes, the bleed stopped. I never see bleeding that continues for a long time, and I'm surprised if you have time to operate the patient, and during 60 minutes is too long time. Normally we can expect the patient is dead. I'm surprised. Normally, when you have a complication, this kind of complication, when we make a control, in 3-4 minutes after, the bleeding stops. Okay, it's often. Do you have this? You can operate in a acute bleeding for perforation.
Actually, that perforation I showed you just one case, that case only. And another breathing complication was small branch pruning injury due to thrombectomy by using a treb or something. By pruning the M1 segment, the small branch was abrupted and the bleeding happened. There are two cases. But it's a rarely happen. But in that case of a perforation, the bleeding was very strong. So with the conservative treatment, the patient may be dead. So we did the surgery immediately.
Okay, and just another point for the test, occlusion test with balloon, we performed before the surgery or during the surgery in the same time, in the same intervention. The test of
current test occlusion before surgery.
Before surgery.
Before surgery, of course. And during surgery, we can measure the MC pressure through STMC bypass.
Okay. Thank you.
Yeah.
Thank you. Jean, you want to ask something or say something about the presentation? Thank you.
Hi, Dr. Tanikawa. It's a great pleasure to be with you again. We have been together 2 months ago in Phoenix during his course along with Dr. Lawton. So I had the such a great privilege to see personally his technique. It's amazing technique. And also the beauty of the case that he just presented to us tonight. Thank you for sharing your great experience with us. Personally, I don't have experience with ischemic case, just the cases you present to us. At the end, you show us the flow chart that you use. First, you use RTPA, and if it doesn't work, you go to endovascular thrombectomy, and if it doesn't work, you go to the surgery.
Yeah.
But the case that you go for the surgery, you already use it, RTPA, you already use some drugs during the endovascular. So you go, when you go to the surgery, you go for such difficult and dangerous situation with a risk of some hemorrhage. How you deal with this situation?
Yeah. It's a good question, and it's the frequent question about the TPA, surgery after TPA. Nothing happened, not dangerous, because many of neurosurgeons are so afraid of TPA or urokinase. But even after using such a drug agent, just 1 hour later, 2 hours later, nothing happened because the TPA, the half time is 2-3 minutes. No problem. Even urokinase, it's longer than TPA. But in my experience, after using urokinase, more than 200,000 or 300,000 international unit of urokinase. And 1 or 2 hours later, I have many experience of craniotomy and embolectomy. I don't have any trouble with hemostasis. So the using a TPA does not matter. No problem.
Okay, TPA, no problem, but the anticoagulation during the endovascular, you use some anticoagulation to perform the endovascular procedure. Yes.
Heparin.
And then after that, you take the patient for surgery.
Yeah. Even after heparin, the coagulation time is prolonged, but we can reverse it. We can reverse it easily using protamine.
Okay.
So, no problem.
Professor,
thank you very much.
in remote areas which you even don't have TPA, or can you go direct to the thrombectomy? Do you think that?
Yes, as I mentioned, if there were no chance to use a TPA, directly you can go to an embolectomy. And if you don't have an endovascular surgeon, endovascular colleagues, that if you wish to save the patient, you can choose the open surgery. Because the opening of Sylvian fissure, exposing an M1 segment, M2 segment, ICA, it's easy for you.
Yeah, but do you feel worried about some scientific support for that, you know? Scientific support, articles, and so on.
Yeah, about the surgical embolectomy, no scientific support, no evidence such as endovascular treatment, because nowadays the endovascular treatment has evidence of the endovascular recognition, and nowadays we are not necessary of the evidence of surgery. Almost cases can be treated by endovascular in my institute as well. So the main role of a surgery after in acute stroke, especially after endovascular treatment, is a treatment of a complication, especially hemorrhagic complication or dissection, something, dissection and dissecting occlusion of the parent artery.
Professor Johimura, what do you think about these thrombectomies here in Latin America? What do you think about it? In Latin America, thrombectomy.
Okay. Can you listen to me now?
Yes.
Yes. I made my first embolectomy in 2013, before the Nashville Hope, like Rokuya. And we talked about this several times. I think that it's very interesting because the thrombectomy is not so difficult, technically. Even if you cannot make the stitches, there are some clips that you can use. For example, Peter Lassie have the tunnel clip that you can open the artery and you can close with a clip if you cannot do a suture, okay? But I think that the problem that we have now is the neurologists are associated with the endovascular. The neurosurgeon is not in the discussion of the ischemia, the acute ischemia. The neurosurgeon came after 12 to 24 hours to do the decompressive craniectomy. That's the only thing that we do as neurosurgeons, okay? But we must know that the endovascular therapy is not available everywhere, and that is very important. In Latin America, we must realize that in some places we lost patients because we don't have endovascular. We must think about this because we take time to have endovascular everywhere. It's easy for me because I am in an institute. I have 5 endovascular, you know, and then we have 24 hours a day, 7 days a week. We have endovascular for thrombectomy, okay? But always we have patients that you can do something for them. I made a thrombectomy 2 days ago. 2 days ago, in a woman of 40 years, because she have a occlusion of the carotid artery, and the patient have only a small core infarction, but have more 24 hours. And then that's the problem of label. We, the neurosurgeons today, are so afraid of label. But for example, the endovascular, they do off-label things all the time, and they are not afraid. They put, for example, flow diverter in M2, in anterior cerebral artery, everywhere. And that is off-label because the FDA only approved to the PCOM, you see, but they are not afraid. The same thing happened in 2013 when the New England Journal of Medicine said that the thrombectomy was the same that the TPA, but they not stop. They continue doing the procedure, and in 2015 they made the Nashville thing, the Nashville Hope, with 5 studies who demonstrate endovascular as the gold standard. I think that we, the surgeons, must be inside the stroke. The thing we must do is be in the discussion of the patients with the neurologist and the endovascular. After that, the patients will come. Maybe not today, but if you think about this, the endovascular have success in 90% of the cases. In 90% of the cases, you can open the artery, you see? But in 10%, they cannot open. And the patient stop the treatment and we wait for the decompressive craniectomy. But we can get inside that kind of patient and do the thrombectomy and be collaborative with the endovascular people. That's the thing that I try to think about this. We in Chile made the first neurosurgical symposium of management of ischemia in 2012. Very controversial. The neurologists were mad in that time because they think this is crazy to open the head to take out a clot. But if you see the result of Rokuya, the results are the same. But Rokuya is very serious, and he stopped to do the microsurgery in 2015 because the evidence is said that endovascular is the gold standard. I'm not saying that we have to operate the patient, but if endovascular is not available, we must do something for the patient. We must not wait for the decompressive craniectomy. I think that the stroke is a good field for the future for a microsurgery. Because when the neurosurgeons, you ask for 100 neurosurgeons, you said, what do you think about revascularization in a stroke? All the neurosurgeons think that we are talking about bypass, but we are not talking about bypass. We are talking about thrombectomy and bypass. I'm sure that most of the surgeons here that never heard Rokuya before, they never realized that it's possible to take out the clot. And to take out the clot is not so difficult. But I think we must be very serious with the data. And then the first thing is go into the discussion, and after that, wait for the patient. But for that, we need to train and we need to discuss. Thank you.
Thank you.
Professor Binshu, want to add something in this panel? Your opinion about?
Hello, Rokuya. Nice presentation.
Hello.
Thank you.
Thank you.
Yeah. Actually, you did a great job, especially in treat the acute thromboectomy. So my question is, most of your cases show that's the thrombos. So this kind of thrombos actually it's also fit by endovascular treatment. So do you have some cases that there's some local stenosis, chronic stenosis with plaques at the local site of the MCA bifurcation like this?
Yeah.
So it's hard to treat.
Yes.
Or
yes.
do you have some cases after failed endovascular treatment to transfer to your?
Yes. Of course, I have. And the last case I showed you with STMC bypass, that case I had the cardiogenic thrombosis, embolism, and atherosclerotic change with plaque at the M1 segment. Mm-hmm. And simultaneously, M2 segment has a very strong atherosclerotic change. That's the reason why, even after the thrombectomy, the intimal injury was very strong chronically. So even after reflow, the vessel could not be recognized, easily occluded rapidly. So, but this condition whether the patient have the cardiogenic embolism with atherosclerotic change or not. It can be understood after opening head. In endovascular treatment or just a TP administration, we cannot know because we can't see the lesion directly. During endovascular recanalization trial, by the feeling of the guiding wire or the microcatheters feeling, that we can indirectly diagnose, oh, there maybe have the plaque or something, very strong stenosis. That's it. But in a surgery, during the surgery, we can see directly the vessel. And we can confirm, oh, there is a very strong yellow plaque, and here must be stenosis. So even after thrombectomy, here must be easily occluded. So we need a STMC bypass additionally. During the surgery, immediately we can understand, decide the next way. This is a very important point.
Yeah. How many percentages of this kind of patient in your theory?
10%.
10%, okay.
Yeah, around 10% in my experience.
Yeah. Thank you.
Maybe less than 10%.
So do you always prepare, save the STA before the creotomy to in case? No.
For emborectomy, the STA is included in the skin flap, not to injure the STA trunk. This is our routine work for frontal craniotomy.
So in case
just simply open the fissure and expose the occluded vessel and the thrombectomy first.
Okay.
Yeah.
Yes, Professor Tanikawa, beautiful.
Duarte, want to ask a question?
Yeah.
Duarte,
good evening, Professor Rokuya. Nice to see you again. Thank you for the lecture. How are you doing? I have a question for you. Yeah.
Just a moment. 1 minute.
Oops.
So we see that for a stroke, there is always a field for us to get in and be more aggressive. You know that the compressive craniectomy is more violent than a simple thrombectomy. And do you think, Mura, that it can avoid the compressive craniectomy, the post-operative? Yes.
It's very interesting. I think we must have some approach to this problem. And then what I did, the first patients that I did, all the patients I did the compressive cranectomy. You see, because it's accepted. Then you go to the compressive cranectomy. You know that this is a mismatch, and you do the thrombectomy, and the patient recover the penumbra. And then what you do after 2 or 3 years, you can convince the people, you know, the neurologists.
Do both. So do the compressive and go there and do the arteriotomy.
You're not going to do some damage to the patient because it's lost. You say, okay, we can do a very, very early decompressive cranectomy, and you take a look. And after that, you can show to them that the brain not swelling, and you don't need to the decompressive cranectomy. And after that, after 1 or 2 years, this is a process. They say, okay, Marcos, you can go to the thrombectomy and not take out the bone. You see, but you cannot go now in 2020 and do a thrombectomy without nothing else, because it's not accepted. You know what I mean? It's very important. Very, very important to have some approach to the problem. The first thing is go into the discussion. You must go with the neurologist. Please invite me when you have a stroke, and we can discuss. No, don't call me tomorrow when the patient is lost. You see, that's the first step. When we get that, we can discuss about bypass or thrombectomy, whatever you want. But the first thing is be involved in the discussion. That's the only thing.
Oh, very nice point, Professor Jorge Mura, because this was one of my questions. I will ask again for Professor Tanikawa if he always goes to this thrombectomy, arteriotomy, and he leaves a craniectomy or he doesn't leave. Professor Jorge just told about his experience now for us. And my other question is about what you think of the perspectives of the future of the bypass surgery and microsurgery for these large and big aneurysms at the paracrinoid region, with the advent of these new flow diverters, second generation, third generation, 10th generation, that they keep reporting that they have better outcomes with less invasive techniques. Do you think it will be the future, or we will continue doing that? Because it's very difficult, it's very technical. We need to achieve great skills to do this, what you do, okay, to deal with this kind of lesions.
Yeah, good question. I think from now, the endovascular treatment, especially flow diverter, will be the indication to use flow diverter will be extended much more. Not only a paracrinoid PCOM aneurysms, but also it will be extended to MCA, ACA, something. Absolutely. With the developing the good stenting devices. But even after the developing such devices, we must have the complication or recurrence of a bad result of the endovascular treatment. As I showed you in my presentation, even after very intensive, very strong packed coiling aneurysm, aneurysm has still recurrence, and not only recurrence, but also the other new neurological deficit like oculomotor palsy, like that. And the patient suffered from so much. And even such the complex cases, patient strongly wish to be treated. And after such a failure of endovascular treatment, always many of endovascular surgeons say to the patient, we have no way to treat you, so you should not come. You don't need to come to our clinic, to his clinic. Go to other surgeons' clinic. And then many of such a patient transferred to my clinic, to my hospital. So the neurosurgeon must respond to such a patient. And in such situation, as I showed you, revascularization procedure is necessary. Without bypass, we can't treat such a complex cases. If the coiling so much inside the aneurysm, stenting inside the parent artery, absolutely we need something revascularization distal to the lesion. So with the developing flow diverter, the absolutely high flow bypass for cavernous segment giant aneurysm will be decreased so much. Not necessary. But some of them have the recurrence, has a bleeding, has a stent occlusion, something. After something happened, surgeon must help the patient. So to save the patient, neurosurgeon have to know the way to save the patient. the way of the save the patient is bypass. Clipping is impossible for such a complex aneurysm. I showed you the coiled PICOM aneurysm. It's impossible to put a clip on the neck. So the endovascular, the bypass procedure must be developed so much from now on by young neurosurgeons. Train, continue train. You guys must train, especially not a high flow bypass, especially low flow bypass, small bypass, using STA graft, using occipital artery to distal cerebral arteries like M2, M3, M4 segment, A2, A3, A4 segment, P2, P3, P4 segment. Small artery revascularization is very worthy in neurosurgery complex lesions.
Claudio, Vidal wants to add something in your opinion because we're at the end of the talk. Claudio Vidal, want to say something?
Yes, I really appreciate your lecture. I had the opportunity to see you in the surgical field about 5 years ago in Helsinki, and your technique is really amazing. I usually say to my residents that you are one of the guys that I see during the surgery that is more impressive. And but from a good point of view, I'm really discomfort with the second part of your class about the surgical treatment of ischemic lesions. And I think that was very good because I'm now with the sensation that I have to change my mind and I have to rethink a lot of therapeutic options that we have. So thank you, and I will have to study more about. I think that a new chapter in ischemic disease may be writing now by you and your team. Thank you.
Okay. Eduardo wants to end the questions and then we're going to the close remarks. Okay, Eduardo, please.
Yes, I have two questions. The first one is about how do you manage the antiplaquetary medications pre and post bypass? And the second one is about training. What's the best simulation you can do? Which way is the best to train, especially for those deep bypasses, for SCA, for PCA? Not so much the superficial ones, but especially those deep bypasses. Which way do you think is better to train?
Yeah. First question, antiplatelet agent usage. Basically, the patient who need a bypass always have the atherosclerotic change. Many of them always have the diabetes mellitus. And everyone knows diabetes mellitus accelerate the atherosclerotic change, and it causes a chronic intimal injury. So these patients always have the easy thrombosis of the microanastomosis. To prevent it, we need antiplatelet, at least aspirin. I usually use 100 milligram aspirin before surgery 5 to 7 days ago, regardless unruptured complex aneurysm or a chronic ischemic patient. And the second question, and after surgery, basically I use aspirin continuously forever. And the second question, the training, especially deep bypass. Yes, deep bypass is difficult. You need off-the-job training. Using a synthetic tube is good enough, and we can use something tissue box, and we can simulate the deep operative field through the opening of a tissue box, and we can train. But we need such a training of a deep bypass. But additionally, much more important thing, as I emphasized in the first segment of my presentation, the training of approach, especially the dissection of Sylvian fissure, preserving everything, separating Sylvian fissure from distally to proximal. The distal Sylvian fissure in a superficial, but by separating the frontal temporal lobe, you can enter the insular system. In the insular system, to reach the insular surface, there is a 23-30 millimeters from the surface of the brain. And there is a distance around 10 millimeter more from the bony surface. And if you go much more proximally toward the M1 segment or carotid, from the brain surface, the distance may be 50 millimeter, 70 millimeter, depends on the patient has the size, the 10 at 100 millimeter. So by separating Sylvian fissure very precisely with preserving veins and with the highest magnification, with this dissecting process, we can train our collaboration by both hands, fingers, arms. And this is a very good training to control your finger in a very deep, narrow area. So all the manipulation in neurosurgery, including distal Sylvian fissure dissection, proximal Sylvian dissection, the hemostatic procedure manipulation, neck clipping to the aneurysm. But with the highest magnification under microscope, these are the very, very effective training. So you need both two-way training. Off-the-job micro-anastomosis training, shallow anastomosis, deep anastomosis. And on the other hand, the actual daily work using a microscope, dissecting fissure, and stitching the dura under microscope completely, meticulously. All the such a procedure is a training for difficult bypass. This is my opinion.
Thank you, Professor.
Okay, we want to close because it's too late here. It's almost midnight. And Igor, please say the closing remarks. And Professor, we hope to have you all together with Binshu maybe next year with us in May during our tour here around big cities here. Thank you.
Yeah, 1 year.
Exactly.
Yeah.
Igor.
Enjoy the Sunday morning, Dr. Tanikawa, Dr. Binshu.
Well, on behalf of our society, I'd like to thank Dr. Tanikawa for his kindness. He's so humble and an amazing experience and an outstanding lecture. Hope to see you very soon, Professor. Only 2 words for you. Arigato, sensei. Thank you very much. And thank you to all the panelists. Thanks, Eduardo. Thanks, Marcos. Thanks, all of you. I hope to see you soon in our next round of webinars. And it's a great pleasure to have all of you here. Have a nice weekend and keep safe. Our prayers and thoughts to all our colleagues, doctors, and neurosurgeons fighting COVID in the trenches around the world. Thank you very much for your presence here. See you.